Appreciate you all coming today. We're going to talk a little bit about macular degeneration and focus on what we're doing to try to address it, and also share some personal experience with you around what it's like living with macular degeneration. So we're excited to share all this with you. February is Age-Related Macular Degeneration Month and Low Vision Awareness Month. And so we're trying to help elevate and raise awareness about the value and impact of research and the importance of vision research funding to try to address macular degeneration as well as other eye diseases and eye conditions. We're going to do a quick introduction, and then we'll have a patient advocate share with you her experience. Then we'll have a researcher who can share experience with research and the work that's happening in Alabama right now and across the country in areas. We'll talk a little bit about what you all can do to try to address some of this, how you can support vision and vision research. Do some questions and answers, and then also provide you an opportunity to use some virtual reality to see what macular degeneration actually looks like and what a real experience for someone who's living with it might be. I want to thank our sponsors for making today's event possible. The Association for Research in Vision and Ophthalmology, ARVO, they help support us, as well as a grant from Research to Prevent Blindness, and Apellis, who is a corporate partner for today's event. I also want to recognize the American Macular Degeneration Foundation for their work in supporting this effort and their partnership in our briefing today. A little bit about who we are. We are the Alliance for Eye and Vision Research. We're a 501c3 nonprofit based here in the D.C. area, and our job is to serve as the Friends of the National Eye Institute and essentially raise awareness and educate about why vision research is important and the impact that it can have on people. We talk about it specifically with the National Eye Institute, although we also support DoD vision research funding, which is also a pocket of funding that helps support vision researchers across the country. Matthew, I'm going to have you kind of come up here and share a little bit about AMDF and our partnership and the work that you all do.
Hi, I'm Matthew Levine. I'm the Director of Grants, Advocacy, and Partnerships at the American Macular Degeneration Foundation. And we're happy that you all have showed up to hear this, to us and to many, maybe 20 million people across America, a very important presentation. I want to thank our speakers for coming today. You'll hear a lot of important things. We are a patient-centric organization representing the interests of those with AMD and those affected by AMD, because when you think about it, it's just not the 20 million Americans, it's those around them who provide care and support, and that is a profoundly huge number. The way we describe the situation in America is that we are experiencing an epidemic of AMD right now. It's kind of an unacknowledged thing. But just to put it in very, very brief perspective of how important this is, especially when it comes to legislature. At the age of 50, 1 in 100 Americans have an advanced form of this disease. And if you try the vision aid device, you'll see what that really means. 52% of the voting population is over 50. So this really matters to people. And as you will hear, it's a profound influence on your life. And at the same time, there are amazing things being done in research. But without the National Eye Institute, this research will not progress at a pace nearly enough to meet the needs of what's happening and will happen. Another quick statistic, if you took all the money that we have as a foundation and added all of the nonprofits that support every different kind of eye disease with research funding, it's 1/10 of the budget of the NEI. So the NEI needs to continue funding, and it needs to remain as an independent institute, and you're going to hear a lot more about that. I appreciate your coming. You can contact us at any time. There's some leave behind materials outside that tell you a little bit more data-wise about this disease.
All right. Thank you, Matthew. A couple of key facts. So, like Matthew said, there's 20 million Americans that are living with macular degeneration. Of those 20 million, the key factor is when it comes to macular degeneration is primarily loss of central vision. So it blurriness, gaps in vision, and challenges that way. Again, you'll hear individual experience. You'll also get a chance to see that later today. It is the leading cause of blindness in older adults. It does not necessarily cause complete blindness. It can cause pretty severe forms of blindness and vision loss, but it progresses as time goes on, especially without early intervention and early treatment and ongoing treatment. Regular eye exams are essential in the diagnosis right now. There's also other work being done to diagnose and identify people who may be at risk earlier. And the other piece of it is that vision disorders across the United States, just to be aware of, vision disorders cost about $199.6 billion in 2025. That is in direct costs as well as the indirect costs of loss of productivity among societal contributions. So, and that study we've got a couple different studies that have pointed that out. That cost is expected to increase substantially over the next 25 years. By 2050, it's expected that age-related eye disease, particularly things like macular degeneration, are potentially going to double over the next 25 years. We have an aging population. 10,000 Americans are turning 65 every day and are then at the highest risk for diseases and conditions like macular degeneration. So with that little bit of background, we're going to provide a little bit of an opportunity to hear from a patient perspective and share her experience. So Jill Adelman is here to talk about her experience with AMD. So Jill, can you come on up?
My notes so I make sure I hit my points. Hello, everyone. I am Jill Edelman. I am a self-proclaimed patient advocate with a background as a registered nurse in a level 1 trauma center in the city of Philadelphia. At the time of my diagnosis, that was my life. The diagnosis changed my life. With a short period of time, I could no longer do what I loved. So I could no longer be a registered nurse, and I had to give up my career. Finding out and thinking about why did this happen to me, there's no answers to that. They still have no answers to that. But that's what made me on a mission to find ways to help others that are afflicted with this disease. And the only way you learn is by talking to people. One of the most important things to realize about macular degeneration from a patient standpoint is everybody is different. So every case is different, every treatment's different, every way that it's handled is different. There was a period of time in my life where I'd wake up in the morning and I'd say, what do I have to learn how to do today? So every day you look for a new way to accomplish the tasks. And these are tasks of daily living. It's what makes life work. I was lucky with the help of my husband to find an organization, because when I was diagnosed over 10 years ago, there was not a lot of talk about AMD at all. It was the deep, dark secret. We finally did have treatment for wet AMD, but do you know what it's like to have a doctor turn around and say, well, I'm going to give you an injection in your eye? We say, put a needle in my eye? Well, that's exactly what they do. So I got lucky and I had treatment, but the dry AMD, they didn't talk about it. So patients, people, we had to get together and we had to learn. The support group that I got involved with was called Bright Focus, and that's what we did. I spoke with people all over the world. And by talking and hearing people's experiences, we learned from each other. By learning from each other, I took a lot of the information back to my doctors, and I would say to them, why didn't you tell me this? I was told I had geographic atrophy from the National Eye Institute when I was evaluated. And the doctor said to me, what did you want me to do? Say to you, yeah, you have something called geographic atrophy, which I understood the words because I'm a nurse, but I don't have anything to do for you, so why am I even going to bother telling you? They need to have the information. So patient education in all aspects of macular degeneration is critical. You can ask all the questions you want. You do have to understand sometimes the answer is going to be, I don't know. And that's okay, because that's still an answer. Open communication and different lines of communication and getting out there to the public to let them know we are there to help. We are there to give you the information, and we're there to establish whatever additional help that we can get. All of this help reverts back to all the research that has gone on. Research is critical. When you lose your vision, you lose a big part of your life. You lose your function, you lose your independence, and it just goes on from there. I lost my career, which was devastating and would be, I think, to a lot of people that love what they do in life. The other big issue was I was lucky. I have a husband. I kept fighting and looking for anyone and anybody to talk to about this. I was able to go to a low vision doctor who was able to really help and give me ideas and show me different pieces of devices. They're not cheap, but in my life, I was able to manage it with the help of my husband, but not everybody can. If you can do one little thing through a low vision doctor who gets no support at all, from what I understand, when I go, I pay her. I do have Medicare. I'm over the age of 65 at this point. I was 57 when I was diagnosed. But I have the opportunity to see her. So I have 1,000,001 devices. Everybody laughs at me because I have 6, 8, 10 pair of glasses, various days. My vision can change from day to day. So depending on what's going on and what I'm doing in my life that day depends on what glasses I take with me or have. It can be all different kinds of sunglasses, all different kinds of prescription glasses. But this is how I learned to function on a daily basis. Never walk out the door without a flashlight or a magnifying glass. That's just a part of my daily attire. This is why all these things are so very important to keep in mind when you're thinking about the safety aspect for your patients, and to make sure that they have every opportunity to get what's best to keep them motivated and functioning. And that's one of my favorite words, is functioning. And you're going to see I have to change my glasses to make sure that I tell you everything that I want to tell you. And there you go. That's a part of my life. Our education is, of course, very, very important. It is, in any facet, it's a medical, in any area, medical personnel always say, early diagnosis with early intervention leads to a better prognosis. And that is a true fact where eyes are concerned as well. And unfortunately, people don't get their eyes examined. Whether it's because they don't have eye insurance, they just don't think they need to have their eyes examined, they're not having any trouble seeing things today. There's 1,000,001 answers. People need to get their eyes examined. It's a critical part of life. Just like you go to your medical doctor for a regular physical, your eyes need to be checked out. Maybe 25 years ago, had we seen a problem, maybe I wouldn't have ended up the way I did. My diagnosis came in 100 days. I had a retina exam because I was having some difficulties, and I did go to an eye doctor. Had a full retina exam. Oh, everything's fine, everything's stable. Went on a cruise ship, couldn't tolerate the lights on the cruise ship, didn't know what was going on. Came home the next day, I couldn't see a traffic light that I knew was there. 100 days, and I was diagnosed with wet macular degeneration and started injections. Unfortunately, the macular degeneration in those same amount of time took the entire central vision of my left eye. So it just goes to show how fast this progression can happen. It's not always going to be slow. It can be just as fast. But if you know that it's happening, if you know you have some difficulties, again, early diagnosis leads to a better prognosis. Nowadays, because of all the research that's going on, now there is even a treatment for dry macular degeneration, which I have both, but in my belief, I think the dry takes vision in a more significant way than wet. Wet, we've been getting injections, so that kind of helps if it dries it up. The research that led to the dry injections are saving people's visions. It's keeping you functioning. It's keeping you in society. It's giving you the confidence that you need. And this is what has to be maintained. We have to continue to find and work towards the cure, just like we've cured so many other things. Working towards the cure towards ocular disease is critical to living a prosperous, healthy, functioning life. I will say, one of the very first interviews that I did, at the end of the interview, the woman said to me, this is probably 9.5 years ago, "In the future, what would be your dream?" And I said, well, remembering I'm medical, your eyes are made up of rods and cones and epithelial tissue. If there was a way to take rods and cones from a healthy eye, regenerate them in a petri dish, and grow the epithelial tissue and the rods and cones and create a way to implant them into an eye and have them grow, it would give people back some of their vision. And that would be my dream, because if I could get an extra line or two on the eye charts that everybody's so familiar with, that would make a person very happy. We're there. It's being investigated. It's being tested. So we're so close. It's taken years, but this is what research has done, and this is why it all has to be maintained. Keeping people functioning, keeping people in the best way, mentally and physically, of the way of life that they could be, is very important, and that's why we have to support this and maintain all that we're in the process of doing, with the continuation of the support for the future of the well-being of everyone with ocular disease. Did I hit it?
So you've heard Jill's experience, and I think that it's important to understand there's 20 million Americans that are diagnosed and known to have AMD in this country. A lot more may not be diagnosed yet, and again, we're expecting that number to grow substantially. So now I'd like to welcome up Dr. Osley, who is going to share some of the research that is going on to address macular degeneration from those early stages. So, Dr. Osley.
Put that down. Thank you so much for coming. I really appreciate it. We all appreciate this. Jill, thank you so much for those moving remarks. I think what I'm going to try to do is explain what scientists are trying to do to address some of the issues that you're faced with. And it's also important that the vast majority of this work is really funded by the National Eye Institute, which, as you know, is part of the National Institutes of Health. So, I'm from UAB, which is the University of Alabama at Birmingham, and we have a large department of ophthalmology. We do have a lot of NEI-funded researchers, but UAB is just one institution from institutions from all over the country, probably in every state, where NEI makes a contribution towards scientific research. So while my perspective is from UAB, this is a national issue. So, as we've already heard, that macular degeneration, in terms of its generic understanding, is a blinding disease in adults, where basically in the back of the eye, photoreceptors die. And once photoreceptors die, their life cannot be restored. However, through regenerative medicine, some of the things Jill was talking about, there would possibly be ways to address this. It's the most common cause of blindness in the U.S. We've heard that 20 million Americans have this. It's probably going to be, most definitely will be increasing as the older adult population increases. It has a financial burden of $50 billion, and this is just in the U.S. alone. Keep in mind that in many countries, AMD, age-related macular degeneration, as it's called, is also the most common cause of blindness. So just to kind of give you some technical information, macular degeneration is actually a more general term. There is what we call a juvenile form, or a form that can usually start in the teenage to into the 20s. It's called Stargardt's disease. It shares many characteristics with AMD. However, it is considered basically a rare disease. However, many of the things I'm going to be talking about today could also be applied to the earlier form of the disease. It's important to remember that for people who are over 75, 1 in 3 Americans will have this condition. So let's look at some of the numbers, and let's try to give some context to this. We hear so much about Alzheimer's disease, which of course is highly appropriate. So many Americans have this disease, and also it is also a huge burden on caregivers and society at large. About 7 million people aged 65 and over have Alzheimer's disease. But actually, it's really important to keep in mind that AMD is actually more common. Almost 20 million people age 40 and over years have AMD. So it's really important when we hear so much about Alzheimer's disease. They do the Alzheimer organizations do, and the nonprofits, et cetera, do a great job of bringing this to the public's attention, also Congress's attention, et cetera. It's also important for us when we hear that we also have to consider AMD as one of those conditions that is desperately need of research funding. So let's talk about what the personal burden of AMD is. Now, Jill described many of this, and I'd just like to give you some examples, and of course you can look at the simulator later in our session. So there's a number of very prominent ways you lose vision when you have AMD. First of all, it degrades your visual acuity. You can see here, this is an example of an eye chart that's blurred out. You may be able to read the top letter, but as you move down, you can see with acuity loss, which happens towards the end of AMD. This is a very prominent disabling condition. It also is important to understand that as AMD progresses into the advanced stages, you have to stop driving. And the reason you have to stop driving is you can't pass the vision test when you go for licensing. In most states, there's renewal laws where when you have to go in, you have to reapply, you have to take the vision test again. But this is a very big burden. It's been shown in research that individuals who have to stop driving when they're older have an increased incidence of depression and social isolation. So again, this is another personal burden. Another issue, and this comes from a lot of the work done in my laboratory at UAB, they have difficulty seeing at night and also adjusting to darkness. I think we're all maybe, if we're going to the movies, we're out on a bright sunny day, we're going to a matinee, we go into the theater, it takes us a few minutes to adjust to darkness. The problem, and that's a normal biological thing, that's true of all humans. However, when you have AMD, it doubles or triples the time it takes you to adjust to darkness. And this just isn't important when you go to the movies, but it's important as you're moving around your environment in your home when you're going out at night. And finally, basically the problem at end-stage disease, when you develop what we call aberrant blood vessels growing, we call that neovascularization, or you develop lesions in the center of your eye, like Jill mentioned, called geographic atrophy, often referred to as GA. What you are looking at cannot be seen. For example, I'm looking at this gentleman right here. I'm looking at his face. If I had end-stage AMD, I could see around, but I could not see his face. And so you can see how socially disabling that would be, how that interferes with everyday function and the pleasure of enjoying every day. There's also psychological consequences, and I think Jill has done a great job kind of describing some of these. Keep in mind, in AMD, once you realize you have it, it is a progressive disease. Among different people, it proceeds at different rates. However, if you live long enough, and people are living a long time these days into the 80s, it can cause depression. You have a lot of anxiety about the possibility of losing your vision, and it also can cause social isolation. So let's think about what elevates the risk for AMD. So there's been many epidemiological studies, many of them funded by the National Eye Institute over the past few years. First of all, advancing age is the #1 risk factor. As you get older, you are more likely to have AMD. Smoking also elevates the risk 3 to 5 times. If you are white, you are more likely to have AMD than other racial and ethnic groups. Now, AMD is the major problem for whites. For blacks, they're 4 or 5 times more likely to have glaucoma and more likely to have diabetic retinopathy. But if you are white, you have an elevated risk for AMD. Also family history, and we'll talk about genetics in a moment. And also it's important, more and more research is showing that the diet is very important. Not just the diet, say, when you turn 70, but as you live throughout your adulthood. If you intake a diet which has a lot of what we would call colorful, leafy, dark green vegetables, you're more likely to be taking in nutritional substances that are called lutein and zeaxanthin, and these all come from the diet. The body doesn't generate these, they all come from the diet. And they're known to have protective effects, particularly during the intermediate, the mid-stage of AMD. So let's talk about some treatment options, and I think Jill has relayed some of hers. So the major, going back 20 years, these treatments did not exist. But I would say over the past 10 years, a number of these have become popular. It started with ranibizumab and bevacizumab, and I'm probably saying those wrong, but there have been more newer ones as listed there. And these are given through an injection in the eye. And you have to be very adherent. You have to go in whatever the course your doctor says, whether it's 4 weeks or 6 weeks or whatever your particular situation is. Some patients really just abhor the idea of getting an injection in the eye. So we really need to develop other ways to deal with not just end-stage AMD, but to prevent AMD and arrest its earliest progression. So this treatment, even though it's invaluable, could possibly be less burdensome to patients. There's also a treatment that came from, was funded by the National Eye Institute called AREDS and AREDS 2, and it's a nutritional supplement focused on lutein and zeaxanthin as supplements, so you take a pill. And it's a treatment for slowing the progression of AMD, and it makes you less likely to have end-stage AMD. So there's new treatments for geographic atrophy being developed as we speak. And in fact, it's important to remember that the fundamental discoveries for these treatments do not come from the pharmaceutical industry. They come from universities, and the universities are basically funded by the National Eye Institute. And so we're really reliant on funding from NEI to make these fundamental biological discoveries possible. And then what happens after they're published, they're out in the open, they're in the research literature, if you will, the pharmaceutical industry then adopts them, licenses them, etc., and then develops, refines, and actually tests new treatments. And so this is really how NEI works with the rest of the industry to develop treatments. It's very important to keep in mind that in 2005, the innate immune system was identified by sequencing genes from hundreds of AMD patients. And it took some time. It took maybe almost 20 years, but in 2023, 2 drugs inhibiting the complement system were FDA approved, and as Jill also mentioned, are now available and can be used in the treatment of geographic atrophy. So there's also new information that's coming out all the time. These studies are also funded by NEI, but they provide information on certain types of lesions that are in the back of the eye that cause problems in AMD, cause your photoreceptors to die, but they've been found to be associated with chromosome 10 and the gene as mentioned there. This means that a genetic link to advanced AMD has actually been discovered. And so now the underlying biology can now be studied, and we're in the process of probing this gene's impact on the retina, which ultimately can result in the development of a treatment. Now, these lesions that I mentioned that accumulate in AMD are called drusen. They're also, I'll just call them SDD. It's a very long term. They're also called RPD, but I'll just refer to them as SDD. And when these lesions appear, particularly SDD, they interfere with photoreceptor health and they cause vision loss. And part of the problem, we don't really understand the true origins of these deposits, particularly SDD. And there is so much research funded by NEI that's trying to get to the bottom of this. The presence of SDD and how many you have, basically the abundance of SDD, so that substantially increases your risk for end-stage blindness. But there's really so much more to learn. In my laboratory, and many of the colleagues I work with, we recognize that there's no treatments for arresting early AMD progression. Let's think about cardiovascular disease. Maybe you're also young, you probably don't have heart conditions, but if you have older relatives, grandparents, etc., we don't wait for someone to have a heart attack before we start trying to figure out and intervening what the process is. So we need to take the same approach with AMD, and that's one thing NEI is focused on. There's also no treatments for preventing AMD in those who are at risk. And when I say those at risk, I listed all those risk factors. You might have smoked in the past, maybe you gave it up, your diet could be better, you're older, you're white, etc. So it's really important to understand that if we actually understood how we could minimize risk in people who don't have the disease yet, this would really be the most beautiful story. It's sort of like analogous to controlling blood pressure and lipid levels in terms of cerebral vascular accidents or strokes. It's addressing the problem before it's damaged the brain. We also have a very poor understanding of the biology of the transition from normal aging. People are getting older, their retinas are getting older, but they don't have AMD. But a certain percentage of those people go on to develop AMD, but we really don't understand why. And then finally, there's really no established functional endpoints for tests for trials, clinical trials that are targeted at early AMD. What this means is that when you do a trial, you have to have a way to show that the group that got the new drug, say, or the treatment did better, and that's usually some sort of test. But the problem is that we don't really have adequate tests. So there's a lot of work at NEI done in trying to develop these new tests. Some of them are imaging, retinal imaging. Some of them are called OCT and OCTA. But others of them are things that we've developed at UAB called testing rod-mediated dark adaptation. So research is desperately needed. So before I end my presentation, there's been a lot of discussion in the media. I'm sure it's being discussed in Congress, all over government. It's certainly being discussed widely among universities and research institutes. And I want to take a moment to explain what indirect costs are, also known as facilities and administrative costs, sometimes called F&A costs. And these are really essential to conducting world-class research effectively at research institutes and universities that's efficient, safe, and secure. And so what do these really include? And this is well known in the government. It's part of government documentation as well. These indirect costs include the cost of utilities, heating, air conditioning, water, lighting, the things you have to have in order to do research, data security costs, all the IT costs, which you all know are very expensive, and we also need high-speed computing and processing capabilities. We also have to have radiation, biological, and chemical safety training and hazard waste disposal. We also need specialized core facilities that are shared among research labs within a university and across universities. We also have to have what I would call regulatory requirements, including research safety, conflict of interest reporting, and human and animal safety research boards. In other words, these are the human and animal ethics boards called the Institutional Review Board or the IACUC that deal with human as well as animal safety. So these are really necessary and essential to conduct high-caliber research, and that's why they're so important to universities. So down on the lower part here, I'll show you a little fundus photo. These are kind of all the lipid-enriched lesions that are really a key part of AMD. And it's very important for us to understand how these form, how we can stop them from forming, how we can arrest them from forming, and maybe even after they're formed, get rid of them. So I just want to thank you so much for your interest in learning more about groundbreaking research in AMD, which is really a key issue for people in the United States. Thank you.
All right. Thank you very much. Just a couple more slides here to give you all a feel for some of the work that's being done and some of the things that we're having here. So, as Dr. Owsley said, research is telling us that proper nutrition can help prevent and stave off progression of the disease. Research is also telling us that we need to look for the loss of dark adaptation detects and detect AMD early. We're doing that through a couple of different methods, including imaging. A lot of people, when they think of medical imaging, they think about radiology because X-rays, they're taking images all the time. With the development of OCT and some of the imaging scans in the vision space, we have a lot more images with the eye. So vision researchers are leading the way in artificial intelligence, early diagnosis, not just in eye disease, but also in neurological conditions and other systemic health issues. Research has led to treatments for late-stage AMD that slow the disease and help preserve vision. And researchers in the vision space have also led developments in gene therapy. The first FDA-approved gene therapy was developed by vision researchers. We're looking at that for AMD. Stem cell therapies used to be ethical concerns with embryonic stem cells. That's no longer the case with the development of us being able to derive stem cells from adult human blood cells. That was again found with research from the National Eye Institute. These regenerative medicine opportunities, sort of how you can regenerate and restore vision potentially in the future, are developing ways that we can get into clinical trials to help treat some of these diseases. So we want to approach this disease from both a early stage, early diagnosis, hopefully even stopping it from even starting, all the way to how do we make sure that we're addressing cures and regenerative treatments that can help restore vision. So what can you do to help support some of these initiatives? What can you do to help support the AMD community and the broader vision community? Support the dedicated National Eye Institute. There have been discussions around restructuring NIH that have popped up. They pop up every so many years, but most recently there's been sort of discussions around consolidations and restructuring of NIH. It's important to value vision. We recognize through surveys across the country regularly that vision is one of the most feared medical conditions. Vision loss is one of the most feared medical conditions. Cancer is often number one. Vision is often number two. People fear losing their vision more than losing loss of limb, more than Alzheimer's in many cases, and more than heart disease. When you lose your sense of vision, you lose a lot of that independence, a lot of that mobility and opportunity. So it's really important that we try to address that and prioritize vision within NIH. We want to support the CDC's Vision Health Initiative. Right now, data from the CDC's website around Vision Health Initiative is not available. It's been down for several weeks. We encourage the administration to look at getting that data back up. That data it's population health. It's focused on helping understand the prevalence of vision loss and vision impairment across the country. We want to make sure that we're addressing that. We want to support Medicare coverage for low vision aids and low vision assistive devices and vision rehabilitation. We do want to make sure that people are aware there is a vision caucus. We encourage everybody to do that, to join that caucus. It is chaired by Representative Bilirakis and Representative Vassie, and we really appreciate that bipartisan support. It's a great caucus, and if you're not, your office is not a member of the caucus, we encourage you to do so. And then support the Early Detection of Vision Impairments for Children Act. That's one of our partners' bills. It was introduced in the last Congress as H.R. 8400. We expect it will be reintroduced again in this Congress, although introduction is pending. So with that, I want to see if there's any questions for any of our speakers or anything. Yep.
I have a question for Dr. Ousley. Could you talk a little bit more about the research that you do and also how it might be is being impacted by the M&A funding taxes?
Sure.
So, as mentioned, my research is mostly focused on studying disease from aging to the early and intermediate AMD portion of the disease. And the reason why that that focus is so unique is most studies are focusing on intermediate disease to try to prevent end-stage disease, that's where blindness happens. But because I'm interested in arresting the progression of a disease really from its early points, my focus is to identify functional and structural endpoints. The functional endpoints are basically trying to identify vision tests that could be used in clinical trials that are actually biomarkers for the disease, risk factors for the disease, that then once a pharmaceutical company using fundamental discoveries from research institutes develops a treatment for early disease, we will have a way to benchmark whether the treatment worked or not. We're also looking at what we call structural biomarkers, which are retinal imaging characteristics from optical coherence tomography, OCT. And these techniques have become so sophisticated that they can identify these tiny little lesions in the eye in a non-invasive way. The one thing to keep in mind about OCT in ophthalmology is that it's a non-invasive look actually right at the retina, right at the brain, as opposed to using imaging techniques in the brain. You can't really see the brain, so it's kind of a very useful approach. And so what we're trying to do is put together the functional changes with the structural changes so we'll understand how the disease proceeds through its earliest stages. And so that's what most of my research in AMD is focused on. I hope that's helpful.
The second part of the question was how are the caps?
Oh, yeah.
How are the caps?
Have you been impacted by any of the caps?
Oh, right.
Yeah.
Well, that's an interesting question because the impacts have not been administered yet. I mean, they've been discussed a great deal, and I think every university in the country is very concerned on capping the indirect costs. I know it's true at UAB, but I talked to colleagues all over the country. So it hasn't happened yet, but I can tell you there is a great deal, I guess to use the polite term, is a great deal of serious concern.
And I'll just expand just briefly on that. Some of the concerns that we have really do stem from if this indirect cap of 15% does go into effect. You know, the administration has said that the average right now is about 30%. There are some that are significantly higher than that. There are some that are lower than that. Obviously, that's how the average works. The challenge is, you know, if you cap things at 15%, and the proposed rule or the order was to basically have that starting immediately on all existing grants grants as well as future grants. The research that's being done at institutes like UAB and really around the country, those that have agreed upon indirects with the NIH, that's factored into their research dollars and their budget to be able to do the research that they're doing to try to accomplish the goals that have been outlined in those research projects. It's important to remember that the indirect rates have been approved by the federal government for existing grants. It's a negotiation, it's a discussion between institutes and the government to make sure that those indirects are justifiable. And certainly it's, if Congress or the administration wants to look at indirect rates, I think there may be ways to do that, but certainly we want to study what those implications are and understand those before we implement them. The truth is if this goes into effect for existing grants, immediately research that is being done at institutes, it may have to stop midway through the cycles, midway through some of these grants, because the indirects aren't going to be able to support the additional lab work, the staff, the things like that are needed to be able to help support these labs across the country. So there's real concerns with that, and frankly, not just with the existing grants, but also with new grants moving forward. If labs aren't able to operate with a 15% indirect, the concern is that we're going to see a significant drop in the amount of research that can be done, and that will be impacting not just vision research, but really all medical research across the country. So great question. It's definitely something that we are tracking and very concerned with. I know Congress is tracking as well. Right now, we've got to stay on it, and it's being held off, but we're hopeful that we can come to a reasonable solution or understanding on better understanding what those caps might mean, and making sure that Congress plays a role in overseeing the ways in which grants are provided and making sure that institutes can operate with the grants that are being provided. Yep.
If you could have Congress take any sort of action on this, what would you have to do? Like your realistic ideal situation, what would you like Congress to do to help support what you're doing, but also research across the country on this?
I mean, I think first and foremost, we need to prioritize vision research. So I think from a global standpoint, we want to make sure that the National Eye Institute is appropriately funded. There are currently 27 institutes and centers across NIH. The National Eye Institute is one of them. Vision research, the National Eye Institute is out of the 27 institutes. There's 13 institutes that are funded more than the National Eye Institute. There's 13 institutes that are funded less than the National Eye Institute. So the NEI is sort of right in the middle there. But I also think it's important to see that the vision researchers have kind of done really, really well with the advancement of the first FDA-approved gene therapy, the advancements in stem cells. So I think it's important to prioritize vision research at NIH and elevate some of the funding available there. We recognize it's a tough budgetary environment, but medical research costs continue to go up, and it's important that we're investing in the future so that we can care for patients that are experiencing these vision, these life-altering conditions, but also hopefully be able to treat people in the future that we can stop vision loss before it even starts, or be able to treat those folks in the future with advancements. So I think that's important. With respect to the indirect cost cap, I think it's important for Congress to fully investigate and understand what the implications of something like that would be. Work with industry, or work with institutes across the country, work with universities to better understand their needs, and really identify potential solutions from the studies of those impacts. I think that's probably a practical approach to make sure that we're identifying what the current needs are, while ensuring that we are adequately meeting those needs without putting the burden on institutes and universities that are already strapped in several areas. So I think that's important to understand what the implications are before we move forward with caps that are being implemented, sort of based on a number that's pulled down from the administration or something that way. So I think it's important for Congress to weigh in on that. Yep.
Just want to add something. It's hard to really gauge the significance of the NEI unless you experience vision loss or know someone who has. But in the modern world, 80% of the information we take care of comes into our eyes. And I'm not 100% sure what I'm about to say, but I think it's correct. I don't think there is a treatment for an eye disease that's out there that was not developed through the support of the NEI. Not one. Whether you're talking about glaucoma, irritective surgery for glaucoma, earlier forms of treatment for AMD, current forms of treatment for AMD, diabetic eye disease, you name it, all of them developed at the
Yeah. Yeah, that pipeline development I think is really important. I think you're going to see if there are institutes and universities that suffer with reductions in research or staff or lab time or things like that, and resources, I think you're going to see some real challenges both in the immediate in terms of economic impacts in some of those areas, but you're also going to see the long-term impacts of that where, to Dr. Owsley's point, you're not going to see in industry being able to pick up those new discoveries and new opportunities that are coming out from institutes and universities every day. And that's what's leading the charge and helping us derive new treatments and new methods and earlier diagnosis and better diagnosis, better treatments, cures, and potentially even restorative vision. All of that is coming from the universities, and the industry sort of picks that up later. So if we're not investing in the research now, and this is not just true of vision, all of medical science, if we're not investing in the foundational research that the NIH overall funds, you're going to see pipelines, I think, dry up in a lot of ways across these industry partners. They already invest a lot of money to bring drugs and treatments to market. It's very expensive to do clinical trials. It's a very long process to be able to bring a drug from an idea or treatment from an idea to market. They're investing there. It's hard to, if you're choosing a dartboard to throw a solution at in your industry, you can invest in the things that you think have some real promise, and that narrows that dartboard, that target. If you're having to invest in everything, which is what the NIH does as a whole, that cost goes significantly higher, and that's why it's so important that we have the NIH to help support that early stage research, the discovery, and the opportunity there. Yep.
I guess just as a result of the AEVR and the cuts, is there a specific number or an estimate on how much money has been lost in regards to the research with AEVR? And then also, is there any maximum job loss or layoffs?
So we don't know specifically about NEI. We know from the reports that there are about 1,200 people that have been let go from NIH from the job loss perspective. I don't know the percent or the number of those that are specific to the NEI internally, but we are seeing some delays and challenges in the grant cycles and the approvals of grants and applications for that. So that is creating some consternation, I think, and some challenges for researchers. From the perspective of the caps, the stated savings that they believe the caps would entail would be about $4 billion by cutting the cap to 15%. I'm not sure how they've calculated that number. I haven't seen the math behind it, but that's the number that's been provided. Obviously, we want to make sure that we're efficient and we're being smart with taxpayer dollars that are going to support research. But institutes already do a really good job of verifying and identifying what's needed in those caps and in those indirects. So I think that's important to understand, and it does go to support jobs and everything across the lab spaces that are being utilized in all of these institutes. So I don't have an exact number, and I don't know that you're seeing job losses yet at a high level at the research institutes, but certainly if those caps go into effect, I think you're going to see substantial challenges with the institutes being able to maintain staffing and maintain the labs the way that they are currently set up.
And we were talking earlier today about this very topic, and if the overhead costs are reduced, in order to find resources to support the ongoing research, they will have to start looking at cutting back on the amount of research. So it's not like more money is going to go to research. In fact, less money is going to go to research because the indirects are the indirects. They're not.
No, and that's where I think Congress can play a role in studying the potential impacts of that and identifying what changes might be effective and necessary to be able to discuss the potential implications of what a cap would be. Certainly I think 15% is it's half of what the current average is, and that's a big cut for a lot of institutes out there, both small and large. All right. Well, thank you all very much. We do have some time left, and we'll go ahead and set this up here for those that want to see and experience what AMD is like. So please come on up, and we will give you an opportunity to do that.